That tireless rhythmic beat at the core of life, the heart, it's incredibly resilient, isn't it? Yet even the strongest pump needs a shield.
Absolutely.
Today, we're diving deep into the world of pericardial and epicardial diseases. We're focusing on two really fascinating, but quite different groups of large mammals, the Camelidae, think llamas and alpacas, and the Cervidae, deer, elk, moose, that family.
Boy, two very different groups to compare.
Yeah. And our mission for you listening is to uncover how basic anatomy, tiny little pathogens, or even, human actions can lead to these pretty life-threatening heart conditions.
The complex picture.
It is. You'll see what's similar between them, but also what's strikingly different in the health journeys. Okay, let's unpack this. So to really get what can go wrong, we first need to appreciate the normal, healthy state. What exactly is this pericardium we're talking about, this thing that protects the heart?
Yeah, okay. So imagine your heart nestled inside this sort of two-layered sac. It's a vital protector, but it can also become its potential prison in a way.
Okay.
The outer layer, that's the fibrous pericardium, think of it like a tough, unyielding container. It anchors the heart, which is good, obviously.
Right.
But critically, it doesn't stretch. It's inelastic. And this inflexibility, as we'll definitely see, becomes a huge problem if fluid starts building up inside.
So a strong protective wall, but one with a pretty major limitation if things go sideways.
Precisely. Now, lining that tough outer layer is the inner part, the serous pericardium. You can kind of picture it like a collapsed, slippery balloon wrapped around the heart muscle.
Okay.
One side of this balloon lines the fibrous sac, that's the parietal layer, and the other side, which we call the epicardium, is actually directly glued onto the heart muscle itself.
Ah, okay, so the epicardium is part of the serous pericardium.
Exactly. It's the visceral layer of the serous pericardium. And between these two slippery layers, the parietal and the visceral or epicardial, is the pericardial space.
The potential space.
Right, potential space. Normally it holds just a tiny bit of clear lubricating fluid. We're talking maybe 1 to 15 milliliters in a dog. Proportionally more in these large animals, but still not much. Just enough for frictionless movement as the heart beats.
And it acts as a barrier too, you said.
Yeah, that whole sac also acts as a physical barrier, helping stop infections, say, from the lungs or other nearby structures, from getting directly to the heart.
It's ironic, isn't it? This vital protection can sometimes become the source of really critical problems. When does that protective shield turn, well, problematic?
That's exactly where things get dangerous. When the pericardium gets inflamed, the condition we call pericarditis, it kicks off this whole chain reaction that can escalate pretty quickly.
How so?
Well, the inflammation makes the nearby blood vessels more permeable, kind of leaky. And that leads to fluid and inflammatory cells starting to accumulate in that pericardial space.
Yeah.
We call it pericardial effusion.
Right.
And the fluid itself can vary a lot. It might be clear, watery serous fluid, or maybe serosanguineous, this blood-tinged, or it could be thick with fibrin, or even purulent, meaning pus, or frankly hemorrhagic, just blood, depending on what's causing the inflammation.
Now, here's the really crucial bit I think that people often miss. It's not just how much fluid builds up, it's how fast it builds up. Is that right? A slow leak versus a sudden gush.
Exactly right. The rate of accumulation is often far more critical than the absolute volume. Think about it. If fluid accumulates really slowly, say over weeks or months, that pericardial sac can actually gradually stretch and remodel itself a bit.
It adapts.
It adapts. So it can end up accommodating a surprising amount of fluid, like we see in some chronic idiopathic cases, or with slow-growing tumors. But if that fluid accumulates rapidly, maybe from sudden bleeding due to trauma, or a ruptured vessel, even a relatively small amount, can quickly overwhelm that inelastic pericardium's limit.
Because it just can't stretch fast enough.
It can't. And that causes a swift, critical rise in pressure inside the sac.
And when that pressure hits a critical point, that's where we get cardiac tamponade, correct?
That's right, cardiac tamponade.
Yeah.
It happens when the pressure inside that pericardial sac gets so high that it equals or even exceeds the filling pressures of the heart chambers during diastole, when they're supposed to be relaxing and filling with blood.
And the right side of the heart gets squeezed first.
Usually, yes. The thin-walled right atrium and right ventricle are the first to feel that pressure and get compressed. This severely impedes their ability to fill with blood returning from the body.
Which means less blood going in.
It means drastically less blood the heart can pump out. Stroke volume drops, cardiac output drops. The body tries to compensate, reflex tachycardia beating faster, but eventually that fails too.
So what would you actually see in an animal then?
The classic clinical signs are really due to this impaired right heart filling, this backup. So you see things like jugular venous distension, those big neck veins bulging. You might see subcutaneous edema, swelling, particularly under the jaw, what's called bottle jaw or in the brisket area, and ascites, fluid accumulating in the abdomen. Classic signs of right-sided heart failure, really.
Understanding that cascade inflammation, effusion, tamponade is so critical. But just to be really clear, how do we precisely define these conditions, like pericarditis versus epicarditis?
Good point. Defining the lesions accurately helps us understand the scope. So pericarditis is the general term for inflammation of the whole pericardial sac, both layers. And we usually describe it further by the type of exudate, the stuff accumulating inside, like fibrinous if there are thick, stringy mats of fibrin, or suppurative or purulent if there's pus. Then epicarditis is inflammation specifically confined just to the epicardium that layer directly on the heart muscle. But it's important to stress, epicarditis is rarely an isolated thing. It usually happens along with broader pericarditis.
Do they often go together?
Very often. And then in the most severe cases, especially with, say, deep infections or maybe a penetrating injury, you can get pancreatitis. Pan meaning all.
Everything.
Everything. Inflammation involving all the heart layers, pericardium, epicardium, the heart muscle or myocardium, even the inner lining, the endocardium. Pancreatitis carries a very grave prognosis.
Right. Okay, let's shift gears now. Our journey takes us to the world of the Camelidae, our llamas and alpacas. And here, the story seems quite different, doesn't it? Often a story of individual resilience, maybe a path to recovery.
Yeah, it's a really distinct picture in camelids. And a key insight is the contrast with cattle. In cattle, hardware disease, traumatic reticular pericarditis, or TRP, is a major problem.
You hear about that a lot in cows.
We do. But in camelids, sources say it's rarely, if ever, reported, or at least less common. And that's likely because they're much more selective eaters than cattle.
Right.
They don't just hoover up everything.
Like pickier.
They're pickier eaters, exactly. So instead, a really significant cause of pericarditis in camelids, especially in the newborns, the crias, is septic pericarditis.
Infection-based.
Infection-based, yeah. See, crias are born basically without their own immune defenses. They're gamma-globulinic. They're completely reliant on getting antibodies from that first milk, the colostrum.
That passive transfer.
That crucial passive transfer. If that fails, for whatever reason, they become immunodeficient and highly susceptible to systemic bacterial infections. These often start somewhere like the umbilicus, an infected navel, or maybe the respiratory tract, or the gut.
And then the bacteria spread.
They spread through the bloodstream hematogenously and can seed the pericardium, setting up shop there. We've seen cases like a 2-month-old llama cria that developed really severe constrictive effusive pericarditis, directly linked back to an umbilical abscess caused by Pseudomonas and E. coli.
Wow. So often a systemic infection finds its way to the heart in these young ones.
Exactly. Though sometimes we don't find an underlying cause. That leads to a diagnosis of idiopathic pericardial effusion. There are documented cases where, even after analyzing the fluid and doing lots of tests, no specific reason is identified.
It just happens.
Seems like it sometimes. We've even seen successful management of tamponade in a pregnant llama, where the effusion was ultimately called idiopathic.
Interesting.
And then we also see constrictive pericarditis, or sometimes effusive constrictive. This is where chronic inflammation makes the pericardium itself thick, scarred, and fibrotic. It loses its flexibility and physically restricts the heart's ability to fill properly, even if there isn't a huge amount of free fluid at that moment.
So the sac itself becomes the problem.
The sac itself, that llama cria I mentioned, it actually had organized, thick, fibrinous material, not just free fluid, causing the compression. And finally, you can sometimes see small, incidental pericardial effusions that are secondary to other big systemic problems like severe congestive heart failure from another cause, or really low protein levels in the blood, or maybe severe pneumonia nearby. But in those cases, the effusion isn't the primary issue.
Okay. So if you owned a valuable llama or alpaca, what signs should you be watching for? What might clue you in?
Well, initially, the signs can be pretty nonspecific, kind of vague. Lethargy, maybe not eating well, and intermittent fever, perhaps, maybe breathing a bit fast or with difficulty.
Things that could be many things.
Exactly. But as cardiac tamponade starts to develop, those more specific signs of right-sided heart failure become clearer. You might see that visible distension of the jugular veins in the neck, maybe swelling developing under the brisket or under the jaw, and fluid starting to build up in the belly, the ascites.
And listening to the heart.
Yeah, auscultation. Often you'll hear muffled or indistinct heart sounds because the fluid acts like an insulator. But interestingly, sometimes the heart sounds can remain pretty normal, especially in cryas. Maybe it's because their chest conformation is narrower, allows sound to transmit better. We're not entirely sure.
Given how much these animals are often valued, I imagine advanced diagnostics play a huge role here, much more so than maybe in other livestock.
Absolutely. Echocardiography, ultrasound of the heart, is really the definitive non-invasive tool. It lets us actually see the effusion, that fluid-filled space around the heart. We can even see fibrin strands sometimes. And crucially, it lets us assess the hemodynamic significance.
Whether it's actually causing tamponade.
Precisely. The hallmark of tamponade on echo is seeing the diastolic collapse of the right atrial and right ventricular walls. They're getting squished when they should be filling.
What about ECG?
Electrocardiography, ECG, gives supportive evidence. Often you'll see that compensatory fast heart rate, sinus tachycardia, and with really large effusions, you might see decreased R-wave amplitude. The main spike is smaller, and sometimes this really classic sign called electrical alternans.
What's that?
That's a beat-to-beat variation in the height of that R wave. It happens because the heart is literally swinging back and forth within the large volume of fluid in the sac.
Wow. Okay.
And there's pericardiocentesis. That's draining the fluid from the sac with a needle. It's vital. Both diagnostically, we can send the fluid for analysis, cytology, protein levels, bacterial culture, and therapeutically. It gives immediate life-saving relief from the pressure.
And the prognosis for these camelids, it sounds, maybe surprisingly, quite hopeful in many cases.
Yeah, if we're connecting this back to the bigger picture, for non-traumatic cases in camelids, the prognosis is generally considered guarded to favorable, which is, a significant difference compared to how we often think about this in other large animals like cattle with TRP.
So treatment is often pursued and can be successful.
Yes. Medical management often involves aggressive, long-term systemic antibiotics, ideally guided by culture, results from the fluid, plus systemic anti-inflammatory drugs. Pericardiocentesis, as I mentioned, provides that immediate relief from tamponade, stabilizing the animal for further treatment.
And surgery.
For cases of recurrent idiopathic effusion, or for that constricted pericarditis where the sac itself is the problem, surgical management is the definitive treatment. Specifically, a subtotal pericardiectomy.
Removing part of the sac.
Exactly. Removing a large window or portion of the pericardial sac. This creates an opening so any future fluid accumulation can just drain harmlessly into the chest cavity, the pleural space, preventing tamponade from recurring. And the surgery has been successfully performed even in young Lomacryas, showing it's a viable option with potentially good outcomes.
Okay, so a much more interventionist and often hopeful picture for camelids. Now, let's pivot completely. Let's talk about the Cervidae, our deer, elk, moose. You mentioned this is a different story, and frankly, it sounds like a far grimmer one.
It really is a stark contrast. And the key difference starts right at the cause. For cervids, the overwhelming, predominant cause is traumatic reticular pericarditis, TRP, hardware disease.
The same thing that's rare in camelids is dominant here?
Exactly. And the process is pretty well understood, mainly from cattle, but it applies here too. The animal ingests a sharp foreign object, a piece of wire, a nail, something like that. It drops into the reticulum, one of the four stomachs. Then the powerful contractions of the reticulum literally push or drive that sharp object forward. It goes through the wall of the reticulum, punches through the diaphragm.
Run between the abdomen and chest.
Yep. And penetrates right into the pericardial sac surrounding the heart.
Oh, wow.
And what does that do? It introduces a mix of bacteria from the gut, maybe bits of feed material, directly into that normally sterile pericardial space. This instantly incites a severe, fulminant, fibrinosuppurative inflammation, basically a massive infection and inflammatory reaction.
And this sounds like it's very often linked to human activity, right? We're inadvertently setting the stage for this.
Absolutely. The risk factors for TRP in cervids are almost entirely tied to human presence and environmental contamination. If they're captive or farmed, they might be exposed to construction debris, bits of old fencing wire, maybe metallic contaminants in processed feed.
Okay.
And even free-ranging populations are at significant risk, especially in areas where there used to be old farmsteads, areas with current agricultural use, or sadly, places used for illegal dumping, where metallic junk gets left behind.
So they just pick it up while grazing.
They pick it up while grazing. There's even a direct case report of TRP in a captive water book, which is ecologically pretty similar to deer, caused by a 12-centimeter bamboo twig. It resulted in what they described as a classic bovine presentation of hardware disease.
So it doesn't even have to be metal.
Doesn't have to be metal. The wire and nails are classic. Now, while TRP is dominant, other non-traumatic causes can theoretically occur. Systemic bacterial infections could potentially seed the pericardium. For instance, Trupperella pyogenes, a common opportunistic bacterium, has been implicated in severe heart valve infections, endocarditis, in white-tailed deer, which then had secondary pericardial effusion.
Okay.
Viral causes like adenoviruses or parasitic causes like certain mycobacteria are also considered plausible, though maybe less commonly documented, specifically causing pericarditis in cervids. And you could potentially see neoplastic effusion from cancer, but again, not well documented in the literature for this group.
It's one thing to diagnose this in a llama that you can handle in ultrasound, but trying to figure this out in a wild deer or elk, that seems incredibly difficult. This raises a really important question. How do you diagnose this in an animal that's naturally elusive and hides illness so well?
That's precisely the core challenge.
Yeah.
Ante-mortem diagnosis before death in free-ranging cervids is, well, it's rarely achieved. It's just not practical.
They hide it too well.
They hide it too well. Wild animals have a strong instinct to conceal any signs of weakness or illness to avoid attracting predators. So, by the time signs are noticeable enough for someone to observe them, the animal's usually already moribund, very close to death.
So those advanced techniques are out.
Pretty much. Advanced diagnostics like taking X-rays or doing an echocardiogram, which are standard for camelids, are described as entirely impractical for a sick, stressed, free-ranging wild animal.
Yeah.
And even in captive settings, because the prognosis for TRP is understood to be so incredibly poor, extensive diagnostics are often bypassed. Humane euthanasia is usually elected instead. Which means that postmortem examination, the necropsy, becomes the primary and often the only diagnostic method.
So for cervids, the definitive answer almost always comes after the animal has died.
Yes, unfortunately. And at necropsy, the gross pathology, what you see with the naked eye for TRP, is considered pathognomonic, meaning if you see it, you know what it is.
What does it look like?
The pericardial sac is usually markedly thickened. It's opaque instead of clear. And it's filled with these thick, shaggy layers of exudate, often yellow, green, or grayish, which is a mix of fibrin and pus. This classic appearance is often vividly described as a bread-and-butter heart.
Bread and butter heart.
Yeah, because the layers of fibrin sticking the inflamed surfaces together look a bit like butter spread between two slices of bread. You'll often find dense adhesions between the parietal pericardium and the epicardium. And sometimes you can even find the offending foreign object itself and trace the fistulous tract it created coming from the reticulum.
Wow.
You'll also typically see secondary signs of that chronic right-sided heart failure we talked about. The nutmeg liver pattern from chronic passive congestion, fluid in the abdomen, ascites, and maybe generalized edema elsewhere in the body.
Is there anything else it could be mistaken for at necropsy?
It's important to differentiate it from, say, the cardiac hemorrhages you might see with certain viral diseases like epizootic hemorrhagic disease, EHD, or blue tongue. Those hemorrhages are usually smaller, more pinpoint or blotchy, and they're due to damage to blood vessels throughout the body, systemic vasculitis, rather than this massive pericardial infection. Histopathology, looking at the tissue under a microscope, confirms TRP by showing severe chronic active inflammation, often with both neutrophils and macrophages, lots of fibrin, and sometimes visible colonies of bacteria.
This really paints a picture of a uniformly tragic condition for these animals, doesn't it?
It really is. The prognosis for TRP in cervids is described as uniformly fatal.
Yeah.
Even in captive settings where intervention might be theoretically possible, the condition is generally deemed hopeless. And euthanasia is the standard recommendation for welfare reasons.
So no real treatment options.
No practical ones, especially in a wildlife context. This means prevention is truly the only effective means of control. And that comes down to environmental management, removing metallic debris, old wire, construction junk from habitats where cervids live and forage. And for farmed animals, rigorous quality control of feed to make sure contaminants aren't included.
It really highlights the environmental connection.
Absolutely. In a broader ecological sense, finding TRP in wild cervids really acts as a kind of sentinel for habitat quality. It's a direct, tangible consequence of human-altered environments and the introduction of hazardous debris.
Okay, let's try and connect all this back to the bigger picture then. This comparison between camelids and cervids is so striking. It really highlights how different species can face fundamentally similar challenges to the heart's protective sac, but with vastly different causes and outcomes.
It's a fascinating contrast, isn't it? You see the clear differences in etiology, Camelids, it's mostly endogenous infection spreading from within, or idiopathic.
Right.
It just happens, and TRP is rare or less common. Cervids, it's predominantly exogenous, something from the outside, TRP, directly linked to environment and human impact.
And the diagnosis follows that split too.
Right. Diagnosis in camelids is often clinical, happens antemortem, and relies heavily on advanced imaging like echo. In cervids, it's almost exclusively a post-mortem finding via necropsy because of the practical challenges and grim prognosis.
And treatment and prognosis. Polar opposites.
Polar opposites, treatment and prognosis. Camelids, guarded to favorable, potential for recovery with medical and even surgical intervention. Cervids, uniformly fatal, hopeless prognosis. Prevention is the only control strategy. It just powerfully illustrates how species-specific biology, like the selective feeding habits of camelids, giving them some protection from TRP, interacts with human factors. We value camelids highly enough for advanced vet care. While our environmental impact creates the primary problem for cervids, it shapes the entire disease narrative.
It really does. So this raises an important question then. What don't we know? Where are the knowledge gaps? And what could we maybe learn or focus on in the future?
Yeah, there are definitely significant knowledge gaps. For one, the true incidence of pericarditis, especially TRP, in free-ranging cervid populations is largely unknown. It's almost certainly underdiagnosed because affected animals likely die undetected in the wild. Systematic surveillance, maybe through wildlife health monitoring programs looking at mortality causes, could give us much better data. The prevalence of non-traumatic pericarditis in cervids is also really uncharacterized. Is septic pericarditis or other forms happening more often than we realize, just overshadowed by TRP? We need more comprehensive pathological investigations when cervids are examined.
And from a management perspective.
Well, thinking about prevention, environmental risk mapping could be valuable. If wildlife agencies could map confirmed TRP cases, could we identify geographical hotspots associated with specific land use histories, like old dump sites or abandoned farms? That could potentially guide targeted habitat cleanup efforts to remove the metallic debris and actually reduce the risk for these animals, improving habitat quality.
That makes a lot of sense. So we've journeyed deep into the heart of the matter today, quite literally. We've explored the delicate balance of the pericardium, that dangerous cascade of inflammation, and these two really wildly different narratives in animal health.
It's quite the contrast.
It is. From the often treatable individual cases we see in valued camelids, where intervention is possible, to the almost always fatal environmentally linked hardware disease predominantly seen in cervids. The story of pericarditis, it turns out, isn't just about heart anatomy. It's deeply intertwined with animal behavior, with ecology, and with our own complex, sometimes detrimental relationship with the natural world.
A very important connection to make.
Yeah, so maybe next time you see a llama peacefully chewing its cud, or catch a glimpse of a deer disappearing into the woods, just consider the unseen battles that might be raging within. Or think about how something as seemingly simple as a discarded piece of wire, a remnant of human activity, can completely rewrite the final chapter of a wild animal's life story. It makes you wonder, doesn't it? What other diseases out there might have such drastically different trajectories depending purely on the species and its surroundings?
It's a crucial perspective in veterinary medicine and conservation.
Absolutely. Well, we hope this deep dive has given you a fresh perspective, maybe sparked some new curiosity about these intricate connections between animal health, the environment we all share, and the impact, intended or unintended, that humans have.